Hello, good day, dear friends. I am Dr. Vardhan, and in this podcast, it is my privilege to welcome Dr. Ramakant Bembde, sir. Dr. Ramakant Bembde is a senior burn surgeon from Maharashtra. Today we have him. So thank you for giving time and welcome to this podcast.
Yeah, thank you so much. It's my pleasure, Dr. Harsha.
So today we are here to discuss a very interesting and an important topic, something that we routinely see in burn reconstruction. This is an article titled Full Thickness Skin Graft versus Split Thickness Skin Graft in Pediatric Patients with Hand Burns. This is a systemic review and meta-analysis. This was published in the Journal of Burns in 2023. This has been published by Abdul Malik Al Saif et al. From UK. So I'll be briefly presenting this article and then I shall be discussing this with you, sir.
Yeah, that's fine.
As we all know, hand-burn reconstructions are performed using split-thickness skin grafts and full-thickness skin grafts. There are pros and cons of both, especially in the setting of pediatric population. There are a lot of studies that are there, mostly observational in nature, sometimes comparative also. But systemic analysis of these studies are missing in literature. So this article hopes to fill that disconnect with giving a meta-analysis of all the trials that are published, especially for the pediatric population. So this systemic review was performed as per the PRISMA guidelines. It took the inclusion criteria were for patients who were less than 18 years of age were included in this. The authors looked from various sources, which were Medline, Embase, MK, Sinha, and the Cochrane Register. When they found that there were about 64 studies present in the literature using in the pediatric population. Finally, they were able to find 10 studies which were finally included in the systematic review. These were the 10 studies that were included. They ranged from originating from America, South Korea, Australia, and Europe. So what did they find? So the primary outcome they looked in these studies was the evidence for the presence of post-grafting contraction. And they found that there were a few studies that supported full thickness graft, full thickness graft causing lesser rate of post-graft contracture. One study said that split thickness graft had lesser contracture, and one study was equivocal. However, it was most of the evidence pointed to the fact that full thickness grafts result in a lower rate of contracture post graft. Similarly, another primary outcome of theirs was subsequent surgical release in patients who had been grafted. And this also showed that there was a lower incidence of surgical release when full thickness grafts were used. This was true in both acute burn reconstruction as well as grafting post burn contraction. Now, in addition to the rates of contracture, they look for other outcomes as well. One of the things that they assessed were functional assessments. And most of the studies pointed that there was better functional results when full thickness skin grafts were used. Spencer et al. One study said that there was much difference whether a full thickness or a split thickness graft were used. In terms of cosmetic and color assessment, there was better results with full thickness graft in two studies. In one study, there was variable degree of pigmentation, and in one study, split thickness skin graft was found to be less deforming in terms of cosmetic appearance and the color match. There were two studies that assessed other outcomes like scar, the quality of scar, the sensory quality, and hair growth. In scar assessment, Chan et al. Found that the full thickness graph had better pliability, while the split thickness graph was having better vascularity and better wound height. Elrod et al. Found that the split thickness graph was superior to a full thickness graph in terms of OSAS and a Vancouver axis. In terms of sensory quality, no difference was found between the full thickness and split thickness graphs in both of these studies. Hair growth was mentioned to be an issue in these two studies, in full thickness graph. So they also checked the, the, the heterogeneity of this study, the comparability of the studies using the Newcastle-Ottawa scale. And what they found was the comparability was low. Only two studies were found to be slightly comparable, while the rest had a heterogeneous population. And hence, that was one of the limitations of this systematic review, that the patient population of all the different studies was not very homogeneous. It had some heterogeneity, which could have led to some biases. Now, at this point, I would bring in Ramakant Bembde sir and take his inputs of the different aspects. So, sir, my first question to you is that in the context of pediatric population, in terms of reconstruction following acute burns, what would be your graft of choice and why?
Personally, routinely we use thick skin graft using a dermatome, which is uniform thick skin graft for majority wounds which are larger. And if the wounds are small, where we can use bilateral groin full thickness skin graft, there we use full thickness skin graft. The thickness should be around 0.018 to 0.025 inches, which can be adjusted on the dermatome for having good results in thick skin graft.
Sir, it is interesting that you mentioned the dermatome. Now, do you have a reason why you're specifically using a dermatome and not a Humvee's knife? Or is it just because you use dermatome frequently?
I feel dermatome gives the precise, defined thickness and uniform thickness. So we prefer dermatome in most of the reconstruction. And coming to the answer to the why I use this type of grafts, in thickish split thickness skin graft, there is a less contracture compared to thin skin graft. Then there is a higher graft take than full thickness skin graft in these poorly vascularized and large areas of burns wounds. And also the donor site healing is also um, uh, there is no any problem in healing of thick split thickness skin graft. These are main reasons why we use thick split thickness skin graft for huge areas.
In terms of acute burns and grafting in acute burn patients, how would you be a proponent of doing them really early, or would you allow granulation to develop and then would you do it? So, what would be your time frame? When would you suggest we
Yeah.
skin graft?
Honestly, in acute burns, we have hardly used full thickness skin graft. We have no experience of using in acute burns either after tangential excision or after having granulation tissue. Mostly we use thick skin graft in hand burns in children.
There is a school of thought, especially in the Western world, which they say that to second degree wounds, perhaps you can debride and put a thin skin graft early so as to reduce the pain and the dressing need for dressing changes.
Mhm.
So, but sir, do you have any experience? I don't think any of us are doing that in where
No,
they use
full thick. Ah, sorry.
early in superficial, in deep second degree burns, they debride and put thin STSGs, thin split thickness grafts.
Uh, See, in children, after wound assessment, if we feel that the wounds are going to heal within 15 days, then we don't excise that wounds.
Mm,
When we feel that the wounds are quite deeper and not going to heal in 2 weeks in children,
mm,
then of course we excise tangentially and we put
mm,
a skin graft on that. That is our
mm.
strategy.
Okay. Okay. Right. So, my next question is, in terms of contracture release, what would your graft choice differ? And
Yeah. In case of contracture release, given a choice, if the area permits for full thickness skin graft, as I said, if the defect is small enough, which can be covered with full thickness groin skin graft, then we preferably use full thickness skin graft. But if the area is larger than that, then we go for thickish split thickness skin graft in contractures.
so is there any difference in terms of using grafts in an adult and a child?
Yes. In case of children, we all know that there is a growth spurt. So,
Mhm,
given a choice, if the things are the area is sufficient for harvesting donor full thickness skin graft, then we go for full thickness skin graft in children compared to adults. Because,
mhm,
as I said, there is a growth spurt. So, the graft should cope up with the growing child
mhm.
compared to the adult where the growth is complete. So there is no any difference in the growth of a graft and growth of the body area of the adult
So you would feel that the full thickness graph grows better along the as the child grows,
child grows.
right, sir?
Yes. Yeah.
Yes, sir. Sir, what is your post-operative protocol in both for a full thickness and a split thickness graph?
Uh, uh, our protocol for both the cases is similar. Either it is
Mhm,
thick split thickness or full thickness. We immobilize, we do tio dressings
mhm,
almost always for all the grafts, and we give a fiberglass plaster splint in children because
mhm,
sometimes the children may break the routine POP plaster gypsum of this thing plaster of Paris. So we use
mhm,
fiberglass, which can be used
mhm,
as a splint later on. Then
mhm,
after on the 8th day and on 16th day
mhm.
of post-op period, we always do under anesthesia dressings in the
Okay,
operation theater
okay,
because we feel
okay.
that they are not cooperative enough to open the
Mhm,
dressings in our dressing rooms without anesthesia.
mhm,
And
mhm,
then we give the proper splints, which
mhm,
patient has to use, the child has to use for almost 1 year. Of course, they
mhm,
may have to change in between. And then we
mhm,
advise pressure garments,
mhm,
we advise moisturizers, and we
mhm,
train the parents for scar massage. Also, we
mhm,
give some scar gels,
mhm.
especially for the areas at the junction of this graft and the normal skin, so that
Okay,
the scar will be supple and mature early. This is our
okay.
protocol. Yeah.
Okay. So do you believe or do you feel there is any need to put a K-wire in the fingers initially to improve the state of the graft?
Yes, yes. When we feel that there is some joint contracture, even there is some subluxation, or the
Mm,
finger is not been easily put in the splint, then
mm,
we judge on table after release, and then
mm.
we don't hesitate for going for KYS. We use thin
Okay.
KYS, which will keep for 15 days.
Hmm. So, but
Yeah.
not as a routine, not in every case.
No, not as a routine. We don't use as a routine, or we don't use external fixator also. There are some surgeons, they use external fixators also as to stabilize the
Hmm.
graft and the
Hmm.
finger
Hmm.
position.
Hmm.
Yeah.
Hmm. And so this splint, how long would you keep it? Till when with the, and how does the patient wear it?
1 year. I advise
1 year.
in children splintage for one
Hmm.
year. Yeah. In adult,
Okay.
we give for 6 months, but in children for 1 year.
Right. Right.
Yeah.
Uh, is there a, I believe, I think we've already covered this, but what I wanted to ask regarding by this question was, does immobilization differ whether if it's a split thickness or a full thickness graft? Um,
No, it's same.
I believe
It's same.
it's the same. So
Yeah.
theoretically, a split thickness graft may have a better take, but for and but splitting his graft would require rehabilitation. Is it difficult in children? Do you find stiffness, or do the children in the post-op period are able to go the exercises uh, once you remove the split and once the grafting is done?
Yeah, it's very difficult in children to go for ideal protocol of rehabilitation. The cooperation from
Mm,
children, especially those less than 5 years, is very less. So, of course, uh, the parents has to be more vigilant and careful about
mm,
this rehabilitation in kids lesser than 5 years of age. There is a problem.
right.
Even for keeping the splints, we found that in post-op, even though parents want, we want, the child is not cooperative enough to wear the splint all the time
Mm, mm,
as per the
mm.
prescription. Yeah.
Sir, do you give a below elbow splint or an above elbow?
Above, always above elbow. Yeah. Above
Even
elbow.
the fiber.
Yeah, yeah. We post-op we always give for 15, 16 days. I mean, two dressings till the
Mm,
graft is completely healed. For first
mm,
2 weeks, 16 days, we give above elbow,
mm,
and
mm,
afterwards, as per the need, below elbow. Means if it is only hand and wrist, then of course below elbow.
mm. So, sir, as far as their primary outcomes were concerned in this, the literature suggests that full thickness graft has a lesser rate of recontraction and resurgery. What are
Yeah.
your comments regarding this, sir?
Yeah, yeah, I agree with that. Definitely, full thickness grafts has better results and less chances of contracture compared to split thickness graft, and also the need of re-surgery in full thickness, the incidence is less.
Right. So, your suggestion would be perhaps as far as possible we use full thickness now.
Full thickness, yes, yes.
Now, in terms of hand function, what do you feel? Is there a difference, and which one is superior?
Yes, of course, full thickness skin graft has better function
Hmm.
than split thickness skin graft. Yes, they are
Sir,
superior.
does there is a school of thought that says that the split thickness graft tends to stick better to the bed and hence may perhaps provide a much more firm support, while a full thickness graft may sometimes move. Is that valid? Is that a valid argument?
Uh, there is no such observation by us. As I
Mhm,
said, full thickness graft we are used for very small areas, the hand,
mhm,
and in
mhm,
that cases we have not observed there is
mhm.
any difference in the grip or function or slippage of things while picking up. There is no such observation from our side.
Right.
Yeah.
Now, in terms of color and cosmetic appearance, what is your experience between the
Yes.
two
Here
grafts?
again. Yes. Yeah, here again also full thickness skin graft has better color and cosmetic appearance compared to split thickness skin graft. Yeah.
There is very few studies. In fact, there were two that had really compared split thickness and full thickness in terms of POSAs and Vancouver scar scale in this study group. So these two were perhaps of the opinion that split thickness skin graft has a better result in terms of the Vancouver scale. So, do you feel that is true, or perhaps because there were so few studies that had reported the Vancouver star or patient observer star scales in this population?
Yeah, I feel full thickness skin graft has better scar quality compared to split thickness skin
Okay.
graft. Yeah.
So, so perhaps it is that just a very few studies. It was in fact only two studies out of the 10 which had reported on these outcomes.
Yes.
And that
Yes.
is why in this population group it had focus. How is the sensory restoration, sir, following grafting in these grafts?
Sensory restoration is similar in both the full thickness as well as split thickness. There is no difference in sensations we have found.
Okay. So, I mean, does it come back to normal or is it inferior to the adjacent normal skin set?
Y- Yeah, it is means 100% it cannot be regained like a normal adjacent tissue. There is a good protective sensation which
Mm.
gradually improves with time, but it cannot be like a normal skin.
Mm. Like, have you observed hair growth following skin grafting following a full
Rarely,
thickness of
yeah, rarely in full thickness skin graft we have seen hair growth.
and then if
Sometimes
in case you do hair growth, so what I mean, does it is it troublesome enough to do something about it or does it settle down
laser
on its own?
laser repellation can be advised if it is
Later.
troublesome. Yeah, yeah.
So, now, as you say that split thickness, full thickness skin graft is the perhaps the graft choice or is definitely better in terms of reconstruction. But one of the limitations is, I believe, the donor side. So, sir,
Donor side, yes.
what is your preference for a donor side? Do you have a side preference, or would you be open? How much donor area are you willing to use while you harvesting a full thickness graft?
Routinely, we use bilateral groin skin for full thickness. Um, in our practical experience, we don't go for any other sides. We just go for thickish skin, split thickness skin graft if that area is doesn't suffice.
Mm. Sir,
We don't
if
have
it is a
experience of any other sides. Yeah.
okay,
Yeah.
right,
Sorry.
sir. So, would you? I mean, if there is one groin is enough for both. So, do you have a preference of which side which groin to take?
No, there is no such
Anything,
preference, right or left. Yeah.
right? Right. Do you? So, sir, how much of this hand would you be able to cover with a full thickness graft?
Generally, 3 fingers. If the defect is up to 3 fingers, it can be very well covered with groin skin, full thickness skin graft. Yeah.
Right. So, is
Yeah.
there a difference in terms of take if you have you're using a large full thickness graft?
Yeah, there can be problem of tech in full thickness skin graft compared to split thickness skin graft, especially if the area is large. And especially in in acute burns there will be less graft take compared to contracture release because I feel the wound is better vascularized in contracture release compared to acute burns wounds.
Sir, on that note, how would you look to optimize the graph take in uh, how would you look to optimize the graph take in acute burn? I mean, does things like say a VAC or a hyperbaric, does these things
We definitely we use WAC wherever we feel that the wound preparation needs WAC, especially in very deep burns, as in electrical burns. We routinely use WAC for preparation of wound before going for skin grafting. And if we feel that the bed needs to be excised, we use Goulian knife, a small knife for excision of the
Mhm,
bed to
mhm,
go up to the good vascularized bed. We
mhm,
ensure that
mhm.
the bed is good.
Right. Sir, does the location of the burn on the hand change your choice of graft? I mean, would you still consider full thickness graft
Mm.
on the dorsum, or would you be willing to put a split thickness for the dorsum?
Not really. We don't have any such choice for full thickness or split thickness as per the location of the defect on the hand. Yeah.
Sir, there are reports of using plantar skin for grafting. That with the understanding that it gives a glabrous skin for the wound. Do you
Yeah.
feel it's
Yeah.
worthwhile?
Yeah, practically we have used in one or two cases plantar skin, and it does well. And definitely it is worthwhile if the donor area is small. This the defect is small enough so that the plantar skin donor area is sufficient to cover that. It is worthwhile. I mean, wherever possible. Yeah.
There is a lot of talk now on skin substitutes,
Uh,
and they are coming up
yes.
in a big way. And one of the
Uh,
core area of perhaps marketing is in contact relief. So, what is your experience in both acute burns and in contact relief?
yeah. Yes, we have used in both the cases, acute burns as well as in contracture, and we almost use all the three types which are more popular in India presently. One is made from USA, one is made from Germany, and the newer one is from Australia. All the skin substitutes we use, and definitely it has better results than using only skin graft. It gives little better results, and it mimics little just like a full thickness skin graft, but we have to use 2 mm thickness. 1 mm thickness skin substitute has not much significant advantage. The quality of scar and the function and the flexibility, the elasticity of the graft which is used on a skin substitute is better. So if the patient is affording, and if we feel that it is advisable, definitely I will recommend skin substitutes. In case of acute burns, it is quite costly to cover the large areas of burns. But of course, in burns contracture, hand contractures, especially in children, growing kids, it is always better to go for skin substitute along with the split thickness skin graft if you are using split thickness skin graft. There is no role if you are using a full thickness skin graft. There is no role of substitute skin substitute in full while using full thickness skin graft. I mean,
So, if I would ask you whether a full thickness skin graft versus a skin substitute with split thickness skin graft, what would be your opinion? Which
yeah,
one
of
would be
course,
better?
full thickness skin graft will be always better. Yeah,
Okay. So, if we have an option of a full thickness skin graft, definitely.
yeah, we
However,
should.
if you're having a tendon exposure or the bed is not ideal for a full thickness, then perhaps a
Skin
double
substitute
substitute
and
and then a
yeah,
splitting. So this you
yes,
would suggest a stage procedure, not a single sitting.
yeah, yeah, yeah. It is. It should be stage procedure.
It should
It
be.
should be
And
stage
what would be the
procedure. Yeah.
difference in time interval? Sir?
It has to be put immediately after the release. Means in case of contracture, and generally, this means it is difficult to name the brand, but it takes around 3 to 4 weeks in some skin substitutes, and in some after 15 days only you can put a skin graft. I mean, yeah, there is a difference in take and the wound condition. So the results are almost same almost equal in all the skin substitutes, but in some skin substitute, we can graft after 2 weeks.
Okay. Sir, I believe
Yeah.
our experience of these substitutions are still not that long to comment regarding the effect of growth. So do they still, I mean, allow growth to happen, or does that is that restricted when you're using still substitutes?
I think there should not be any problem. I have used skin substitute a lot. In fact, I had clinical trial for this comparison of skin substitutes also, and I never seen in the short period of 3 years that there is any hindrance in the growth of a child. I have used in children also this skin
Right.
substitute.
Moving on, sir. Uh, Implications that I believe we have already covered this. So just review what in terms of full thickness or the split thickness, is there any difference in growth?
Yeah, full thickness skin graft grows well
Good, good.
compared
Right,
to
sir.
the split thickness skin graft.
Now, sir, in some situations, we may require a distraction where it is a long-standing contracture and it may be partially reduced and rest needs to be distracted. In such a scenario, what would be the graft of choice?
Ideally, there should be flap. If there is a distraction needed in a contracture case, it should be covered with a flap. But
Okay.
if that choice is not there, if you are comparing full thickness, split thickness, then full thickness is better
Yes.
than split
Right.
thickness if you are going for distraction. Yeah.
We see that it is a very common topic, right? But there are few studies that have been included. Eventually, they just came out to have only 10 studies that they were able to include in this book. And so, why do you feel so? It is why are there so few studies on this topic?
See, in this article, most of the studies, 80-90% studies are from Western countries where the incidence of burns is as such less.
Hmm.
And the countries, Asian countries like us, where the incidence is quite high, we don't do such
Yes.
many studies. We should do it actually. We,
Hmm.
being Indian, we should be doing such studies so that we will have our Indian perspective of this experience. Yes.
Which brings me to the next question. Is it possible to do a
Yeah,
trial in our scenario? And is it worth it? I mean, are
yeah,
there
yeah,
enough
it is quite worth it.
I
We
mean,
should go for trial.
is there enough lacunar in the literature to do a trial, or whether it is? I mean, we can come to the consensus that a full thickness graft is perhaps better.
Hi, if you want to study, there are some things which are missing, as you said, comparison.
Hmm. Hmm.
So we can go for a bigger study, larger case series to come
Hmm.
to the conclusion where there are
Regarding
some
perhaps the yes,
disparities
regarding the
between.
secondary outcomes,
Yeah.
yes. Yes. So, so, so my next question to you is: does FTSG grow as per the growth of a child when used for defects after contraction release?
Uh, yes, FTSG grows better than thick split thickness skin graft in a child, but definitely the growth of FTSG doesn't match with the growth of certain structures like hand, which are rapidly growing in a child compared to the growth of full thickness skin graft.
Okay. So, would you think why is a thick STSG a good alternative to a full thickness skin graft?
Uh, this thick split thickness skin graft is a good alternative to full thickness skin graft because it combines both the characters of split thickness skin graft, that is pliability of split thickness skin graft, and the durability and the resistance to contracture of a full thickness skin graft, provided the thickness of graft ranges from 0.45 mm to 0.63 mm. So it combines the advantages of thin graft as well as advantages of full thickness skin graft. Also, there is a higher graft take compared to full thickness skin graft in case of thick split thickness skin graft. And the healing of huge area of a thick split thickness skin graft is better in children compared to the huge areas of full thickness skin graft harvest. These are, I think, three things which we should consider.
Sir, coming on to donor side, we'll talk about donor sites a bit. What are the factors to consider for selecting an appropriate donor site for hand burns and post-burn contractures in children?
The ideal donor site should provide the graft should be pliable, durable skin with good color match and texture match, and there should be quick healing of the graft with minimal complications. And the donor site also should heal uneventfully. So uh, these are the factors I think we should consider.
So, sir, as you mentioned these factors, I would like to go in detail in each of them. So, what are the implications in graft donor site in terms of skin thickness and elasticity?
Pediatric skin as such is quite thinner than adult, but it is more elastic than adults. And thicker donor sites like thigh provide durability of graft.
Okay. So, you mean a thigh may be a better graft
Better,
as well?
yeah,
Okay.
yeah.
So, in terms of color and texture match,
In terms of color and texture match, the inner thigh, then inner part of upper arm and groin areas are closer to the color of palm and dorsum of hand.
what about ease of immobilization and dressing purposes?
Thigh is, of course, the most convenient to immobilize and to dress in children.
And sir, in terms of scarring at the donor site, how does that affect?
Of course, we should avoid cosmetically sensitive and commonly exposed areas like forearm, calves, or chest areas as a donor site, unless they are necessary in very massive burns. And common donor site in children we should use as a anterolateral thigh if there is a large area is needed, and it provides good thickness and good elasticity. And of course, upper arm, the particularly the inner side of upper arm gives good color match and moderate thickness of graft, but there is a limited area compared to thigh.
So, you seem to be favoring the thigh as a donor site a lot, sir.
Yes, regarding its thickness, thigh is better than other areas. And regarding the color match, cosmetic appearance, the inner arm is good choice. Yeah, yeah. Second outcome, some disparities. Yeah, yeah.
So, sir, thank you so much. Uh, this brings us to the end of our list of questions. In conclusion, I think we can say that full thickness graph is perhaps the better graph, and whenever possible, a full thickness graph should
Yeah.
be used. There is a role of split thickness graph, but well-planned comparative studies can help highlight the difference between the two. Thank you so much, sir, for
Yeah.
giving your precious time
Th-
and shedding light on this important issue.
yeah.
Thank you, sir.
Thank you, Nabi. Thank you, Dr. Harsha, for making me comfortable in this my very first podcast. Hope
Right.
the audience will enjoy it. Yeah. Thank you. Thank you so
Thank you so much.
much.
Thank you.
Thank you.